I'm Dr. Jeffrey Sagal, and I'm happy to invite all of you to Baltimore County Fire Department's EMS Academy training series tonight. Our guest speaker tonight is Dr. Harold C. Cohen, who is a retired Deputy Chief from Baltimore County Fire Department. Harold and I go back over 40 years. He was actually my paramedic instructor, among things. Dr. Cohen, again, he was the Deputy Chief for Emergency Operations and the Chief Paramedic or EMS Battalion Chief for Baltimore County Fire Department in the past. He was a Paramedic-Instructor, a CRT-Instructor, an EMT-Instructor, and he's a member of Pikesville Volunteer Fire Company. Currently, he is the principal in Cohen Mediation, which is a firm that provides alternative dispute resolution. He teaches multiple programs at the National Fire Academy, including the research portions of the Executive Fire Officer program. He's a part-time professor in emergency management for Capella University. He holds a Ph.D. in health services from Walden University and an MS in emergency health services, administration and management from UMBC. He got his undergraduate degree at Towson University, and he has been a fellow at the Harvard University JFK School of Government in local executive leadership. I think EMS research sets the basis for everything we do, and it helps us move forward. You can't have an efficient and advanced system without it. So with further ado, I present to you Dr. Cohen, and we will get started. Thank you very much.
Very good. Good evening, everybody. It's great to be here. Again, my name is Harold Cohen, and we're going to talk about EMS research. And hopefully we're going to have some time for some questions later on. Again, a lot of you, or most of you, have different levels of understanding here, from very basic all the way to somebody who know as much as I do, or even more about this. But when Dr. Sagal contacted me and asked me if I wanted to make some kind of presentation, and I thought about it, and I said, you know, I want to talk about EMS research, but I want to talk about the practitioner's role, because in the years that we've been doing this, I don't think we've ever addressed that. I don't think we've ever really told EMS providers what they're supposed to do. And we have to start from the EMR and go all the way through. And you know, we talk about EMS research, but it's really a misnomer. It can be fire, it can be community risk reduction. We just happen to be talking about EMS. We're going to talk about identifying practitioners and who should be doing this. What are some rules? What are some things that we have found that some are things you'll have some trouble dealing with, but others are very exciting here. And so we'll talk for a little while about these things, and then I'll stay and play as long as you'd like to, as long as you have questions. Just for my disclosures, I am a former Baltimore County Fire Department EMS Chief, member of Pikesville. I'm not being compensated for this presentation, and I have no connections to any equipment or drug companies. The most important thing I want to tell you, though, is regardless of what I might have to say, continue to follow your established protocols, the direction of your EMS system leadership, and your EMS medical directors. And that will keep you safe. I'll give you some things to think about, but one of the ways research works and developing an evidence-based EMS system is that we do what we're supposed to. So what are we talking about here with EMS research? Well, I think we're talking about a lot more than most of us realize. First and foremost, are we helping or at least not hurting patients? And we say, well, haven't we been doing that? Well, I want you to think about that. What about mask trousers? How much money, time did we spend training? All the regulations? And we found out that there really wasn't enough research done to tell us, was that the right thing? Were we helping or hurting? And it put EMS in a position where we said, gee, we just have to get rid of them. Well, was that the right thing to do? Well, we didn't know. Now we're getting to the point that we know about things. Secondly, what about EMS system questions? It's not just clinical medicine that we have to be concerned about. We have to be concerned about our EMS system. And some of those questions are even harder than clinical medicine. What about you, the practitioner? What's your role in this? Well, by the end of the time I'm finished speaking with you, you should be able to understand that you have a significant role, whether you're an EMR, an EMT, or anything above, whether you're a medical provider from nursing or physicians or respiratory therapy or athletic trainers who were involved in EMS, you are the backbone of this. And without you, it's never going to get to where it needs to be. When we started out in EMS some years ago, people thought, well, that's for the doctors. That's for the academics to do. Well, no. Physicians in and of themselves have no more of a background than you do. It's not in their standard curriculum. It's now in some of our emergency medicine residencies, and we even have a subspecialty in EMS, but that's recent. So don't think that just because people come from other areas of medicine that they know this any better. And they can just do it all. So what we're saying is, what is EMS research guide? Clinical practice for sure, education and training, EMS system management. How about the EMS supply chain management? Before 2011, nobody even worried about that. You just ordered the drugs and they were there. Not anymore. We have to come up with, how do we do that? How do we combine research in clinical medicine and research in system management and finances to do these things, to make sure you have what you need? Everything about EMS is research-based, and therefore everybody needs to be involved with that. Now, there are dangers in doing EMS research, but to be part of the research community, whatever part you're going to play, you need to understand that you might not like what you find. Some people don't want to hear that. Some people say, I just want to do this so I can prove that I'm right or we're right. But it doesn't always work that way. Matter of fact, that's part of being a profession. And that is that you may realize you might not like what you find, but you have to be willing to do something about it. Have we been doing it wrong for all these years? Won't be the first group of people. Hey, isn't this neat doing all this research? Can't we just predetermine the answer and then make the data fit? There are people who do that. Are we really making a difference in pre-hospital care? I truly think we are. but I'm challenged that we have to continue to prove that. And probably some of the hardest things that we're going to have to be able to do if we want to be involved with EMS research, if as EMS providers, we want to be medical professionals, is we have to be ready to discard what we've stood for and believed in when the evidence tells us something else. That's not easy for us to do. It's not easy for physicians to do. It's not easy for nurses to do. But we've all been put in that position, and we will be put in that position even more as time goes on. And we're going to talk about some of these things. So anytime we exercise leadership, like we do in EMS when we research, there are dangers we have to be aware of. But you know what? I think the best is yet to come. Based on our technologies, the next 5 years will dwarf the past 25 years in EMS. I've always thought myself as a progressive thinker, even in my younger days in EMS. But I'll be honest with you. Did I ever think we would be administering blood in the field? And I would be lying to you if I said I always knew we would do that. No, I didn't. How can we do that? Don't we have to have 14 gauge needles in place? No, we don't. But we didn't know that back then. We know that now. Pre-hospital ultrasound. Who ever thought that? How about alternative destinations based on our assessment? Does everybody have to go to the hospital? That's a 1960s model of emergency medicine. I know, unfortunately, though, that's what we're reimbursed on. And those of you involved in management, we're still in that because our research has been minimal. Where does artificial intelligence fit in? Will it help us provide better care? Will it help bridge some of the gaps in EMS? Or will it be just another technological slave and we become the slaves to it? Paramedicine? Oh, you've heard all kinds of things about it. What we can do is post-surgical. Can we do community risk reduction? But what we need to figure out is not just what we can do, what should we do? What does our community need? If the nursing community is doing well in out-of-hospital, post-hospital care, do we have to keep repeating that? Is there something else that we should be doing? But that's what research does. We can figure that out. Can we treat and release? Military medicine's been doing that for years. We've still been a little reluctant to do that. But what about, can't we get sued? Of course you can. How often does it happen? We do know, been published out of Florida, about 1 out of every 40,000 patient encounters that EMS has will result in some type of significant legal situation. Not even necessarily a successful lawsuit, but where our EMS staff and our medical directors are going to have to be involved. And I remember when I was the chief of EMS, there's 2 or 3 calls a year that I really had to get involved with because we got ourselves into some situations. What's this thing about pain? When you ask people, what was the most important thing that they did for me? Or you ask their relatives, they'll say, pain management. Now, we have always been afraid of that until somewhat recently. But how do we do it? What's the best way? We're still finding that out, but we're getting more choices. And we'll talk about our next adventure, at least in my opinion, and that is, how about at the basic level, the EMT basic level? Is there something that can make things happen? Can we actually prevent more use of opioids and the problems that go with not just the administration of them? That's the easy part. It's all the other management things and regulatory things. I don't know. And I think we're going to determine some things we do are for the good of the patient. And they're going to set examples for the rest of medicine. It won't just be a trickle-down effect. One thing that we don't have a lot of facts that have been published on are these things about STEMIs, and now even non-STEMIs, stroke, trauma, sepsis. I've done research on this as a consultant. And there were several places where we found that STEMI patients who were treated by EMS got treated faster in the hospital than if they just walked into the hospital. At the time we found this, the people I did it for wouldn't let me release that information because they said, we don't want the hospital to look bad. But that's not what this is all about. Is it in the best interest of the patient? And whether we find it or it comes from the hospital, it comes from other medical facilities. We've got to do what's right. And that's going to be our obligation if we're able to do that. Whether it is the EMS medical directors, the EMS chiefs, the fire chief, or our individual providers, whether it's career or volunteer, because that's an important variable in some things that we tend to forget about. But I think the best is yet to come. So let's go for the ride. Hang on, get involved, and we'll talk about how to do that. So what are our challenges? We tend to blame the fire suppression for working in silo mentalities. This department won't work with that one. Fire prevention, risk reduction won't work with fire suppression. EMS and nursing, physicians and EMS. The challenge still is we have to consider ourselves as an integral part of the team. And we have to do that before we expect anybody else to. We're fostering collaborative growth. And the challenge is to expand who we are. Who are we? we have to produce scientifically sound research. And that means knowing the rules, even if they're not determined by us. Even if they're determined by people we are not used to. But they contribute to producing scientifically sound decision making. And again, we have to explore, what should our scope of practice be?
Not that I don't want the information, but there's no point. If we can't find the chat to sign in to get credit for it.
I'm going to turn that over to one of our system people. And while we're doing that, I'll just continue talking a little bit. We have to be ready to accept that. And we have to be ready to understand the challenges. Not all EMS systems will be the same. Yes, we'll have an EMS protocol. We'll have a state protocol. But it really will start to turn more into a scope of practice. And what one EMS provider will do, the other may not, even if we train everybody. And that's a hard one to swallow. And when I was 22 years old, you'd had a hard time convincing me of that. But nobody ever really explained it to me. And also, what shouldn't we do? Is there anything that we're doing that shouldn't be done? And we've got to retire some of those things once we find them. I'll give you one of historic examples of, gee, if I could have handled this differently. And that was the use of antiarrhythmics, lidocaine. We used to give that to everybody. Thought we were doing them a favor. But two physicians at Sinai Hospital actually were some of the main people who discovered that, no, maybe these types of antiarrhythmics are doing worse. Why didn't we catch on to that quicker? It's because we had trouble with that collaborative relationship. There wasn't good contact and good practice review to say, folks, you need to look at this. And for us as EMS providers to say, you know, you might be right. We need to look at this. And we stunted a lot of growth with that. And yes, we hurt some feelings that we didn't have to. And that's just one example. And you all probably could think about a lot of others. And well, we can talk about some more things. Let me give you one example of some of the things that are being considered, we're being challenged with. Is there really a paramedic shortage? First thing when I entertained this was, I can't believe I'm asking this kind of question. Isn't there? Well, what do you mean by that, Harold? What's a paramedic shortage? How many paramedics do you require? And I've had EMS systems tell me, well, we need to have 2 paramedics on each transport unit and 2 on each fire engine. Well, no wonder you have a shortage. And now that fewer people want to move into this, do we have a shortage? Or Are we just not using people the right way? What do we need? How about the new EMT scope of practice? Will this change our thoughts for the future? We're not magicians. We just can't conjure up paramedics. But the EMT scope of practice is not what it used to be. Think about what our EMTs and what their scope of practice could be. The only thing I think is missing for us to head in that direction is pain management. And I kid Dr. Sagel about this all the time, but I'm a firm believer that we should be adding nitrous oxide to the system. Well, okay, Harold, you can say that. How will we do it? Is it safe? Well, I think so. I think dentistry has shown that. But Harold has EMS. And what I wasn't ready for just happened a little while ago, that one day the price of nitrous oxide gas doubled. Oh my gosh. So your idea is great, but you got hit across the head by something you didn't really consider when you should have. Now, I'm not giving up on this. But again, we've got a lot more work to do. Will technology be helping us or hindering us? Now, think about that. Again, something that was a challenge to me. When people said, well, maybe more of our calls can be EMT level, and using artificial intelligence, the EMT can have access to information that can help them. And as the smug, self-righteous person I was, when it came to this, I said, well, no, you shouldn't have to follow all these books and guides. When you're in the field, you should be able to practice. But that might not be the best thing for us to do right now. Think about it. If you're in a small EMS system who sees conscious VTAC once every 5 to 7 years, maybe for patient safety, somebody flipping something open just to follow it might not be the worst idea in the world. Should the paramedics' role be adjusted? We still need them. We need them for the small percentage of calls that really require that level of care, but also we need them in the assessment role. Can paramedics help determine whether we can release patients to EMTs? And is it the right decision? Whatever we decide, most of us understand that where we are now is challenging. We've got to find the right direction. So what we accepted in the past, is there really a paramedic shortage? Needs to be thought about again, using 21st century thinking, in fact, not 1970s or 1980s thinking. And that's all going to come from you. I'll be long gone when you figure this out. But you're going to be the decision makers. And that's why you have to be part of research. I know some of you are thinking this is heresy. Well, yeah, it might be. But it doesn't mean that maybe we have found something that we better be working with. Let's take another thing about this paramedic, getting a paramedic there quickly. Now let's look at some other things. How about epinephrine? What have we determined? In fact, the best thing we can tell you right now is it's time sensitive. We also know that early epinephrine in cardiac arrest is associated with improved neurological status. People come out upright and tax-paying. We're now saying, does the dosage and route matter? And as you see, some of the recent research has said we're not quite sure. What if you can't get an IV or IO line? What if you don't have paramedics? If we can get an EMT there quickly with the ability to get that first dose in, which is very important, will we do just as well? And the answer is, the evidence is not clear that we would not do just as well. If you look at some of these, and if you start to understand statistics a little bit, you can see what you see here says, we're not 100% sure, but you know what? There's a possibility. We need to consider this. Should we consider allowing EMTs to do this, especially when paramedic level care or even intermediate level care may not be quickly available? Think about that. We're all human beings. Are we ready to let somebody else play in the sandbox? Can we afford not to? Think about it. So Harold, what are you trying to tell us? You know, have you been standing in the sun too long or getting dehydrated? And I hope not, but I'm trying to tell you to be curious. Question. Don't take anybody's word for it. Just because somebody is a physician at Hopkins or an EMS staff member or a volunteer chief, that doesn't mean what they have to say passes scrutiny. It means A, they have to be evidence-based, and B, they need to be willing to answer questions from people like yourself who are out there doing this. Have we really figured out what we're looking at? I gave you a bit of light statistics, and some people might think is mumbo jumbo, and they may be right. Do we know what we're looking at? How about what we're looking for? Back in the good old days, it was, well, do we get the person to the hospital alive? And what if we didn't do it? Well, now we're also looking at a number of other things, not just alive, but how well are they functioning? And it's not just the cardiac arrest or the acute MI. How about the painter who breaks their wrist? Following that patient along, there's some significant things about how that patient's cared for that we may have a lot to do with. So no, they didn't live or die because we treated them. but maybe that painter got back to work quicker. And we're going to also talk about, yeah, Harold, how do we get involved? Good question. We have to try. We have to understand we're going to be working with people maybe we haven't worked with before, under rules we haven't worked with before. And it might not be easy. And we're starting to do it. And I'll show you some examples. So this is nothing new. It's just something that's become more critical for us. All right. Here we go. Well, where do we look? Hey, GEMS is okay. Firehouse is okay. But it's not everything that we need. We need to look at recognized scientific journals who do original research. We'll talk a little bit more about that a little bit later. The National Association of EMS Physicians published pre-hospital emergency care. And oh yes, you don't have to be a physician to join that group. There are professional memberships. The American College of Emergency Physicians has one of their premier publications, Pre-Hospital and Disaster Medicine, a new international journal of pre-hospital medicine that is staffed by and overseen by physicians, nurses, and EMS providers. Don't forget about things like public health. And we'll talk about what not looking at these things earlier in the development of EMS recently did to us. Before 1979, when emergency medicine was recognized as a specialty, one of the criticisms was by other specialties, surgery, internal medicine, where is your academics? Where are your academics? Where's your science? Where is your body of knowledge? And that led to things like the Journal of Academic Emergency Medicine. The Department of Transportation put out an EMS agenda for the future. One of those parts was research. And yes, those fire-based EMS programs, the International Fire Journal of Leadership and Management, published by the University of Oklahoma, is a peer-reviewed journal with high professional standards that publishes about managing fire and EMS systems, leadership and management in community risk reduction, where I think we should all know there's just a lot of EMS there that we can do. Is there a tragedy in EMS research? Yeah, there is. Sometimes we slay a beautiful theory by finding an ugly fact. But I like doing this. The fact is, we don't need to do that. Or we might not be doing the best for our patients. And that's hard to hear. And believe me, it's not just EMS providers. There are physicians who say, I've been doing this for 35 years, and I know that treating this chemo patient with surgery, radiation, and powerful medicines is the way to treat this patient. Maybe not. So this is just not a paramedic EMT thing. It's everybody in medicine. So I gave you that example to get you to think a little bit. What is this thing, EMS research? What's it all about? Is it just for a few stuffed shirt people who have academic degrees and don't want to get dirty? No, it isn't. It's everybody, because we have to determine efficacy, effectiveness, and efficiencies of emergency medical care. And that involves all of us. It involves a process in which we have to do that. And there is a process. And we're all the judges of that process. Because if somebody who publishes research and says we need to go in that direction, they have to be judged by their peers. And you're one of them. So you need to know what you're looking at. What kind of research is credible? Well, there are certain things that many of you heard about, and I'm not going to address them real deeply right now. But one of the methods is random selection, double-blinded. Well, what do we mean by that? Who should pick the people that we're going to research? Well, how about the chief? Well, that's not random. Well, how about the medical director? That's not random. What's this blinding? Can I participate if I'm given envelopes with vials with medication in them, and you may not know what you're administering? Well, what if? What if? Aren't I going to hurt some? No. Things are going on behind the scenes that we're making sure that we're doing our ever best not to hurt someone. We don't always succeed. Sometimes we blind the patient. Sometimes we blind the provider. Sometimes we just blind maybe the doc in the ER. Think about it this way. How else do you credibly find the answer when somebody says, I just don't like that medicine? What if that medicine is what the person and our patients need? Let's do a study. Let's blind certain people. And then at the end, we'll find out what the real answer may be. We have to be willing to do that. We have to be willing to answer for our actions and follow rules that somebody else might make for us. What we do most of the time is what we call convenience sampling. And that's when the doc or the chief or the researcher says, I'll pick the people. How about these people? Do we know about them? We don't know. Now we have to do that sometimes. And it's a start, but it's convenience. Well, can't we just look at our EMS charts and take the information from there? That's what we call retrospective analysis. Okay, that helps, but it's already happened. We haven't designed the investigation to answer the questions we need answered. But it's a start. Well, can't we just combine all of the articles and say, I found the answer? No. What you're talking about is a meta-analysis. It's very academic. And yes, it does combine studies. But you also have to combine methodologies, equipment, environments, people, what are their education levels, etc. And that's very hard to do. And while EMS has to do this, we don't do this alone. You have to be part of it, but we need to rely on our other parts of the EMS profession to help us with this and be there. Well, all right, Harold, let me go. I might be able to go into the ER and pick up a Journal of Emergency Nursing or Annals of Emergency Medicine or Annals of Surgery or one of those. I'll take a look at it. But how do I know what to look for? Well, gee, we could spend years on that. We don't have that kind of time. Take some college courses on research. You'll learn. And then you have to practice it. Because if you ask people, what do they really want to forget? Sometimes it's how to do all this stuff. But these are the things that you usually look for. Usually, peer-reviewed articles have an abstract, an introduction, some type of literature review, methods. What did we find? What did it mean? And can we make any conclusions out of it? Well, I would like you to look further and follow me and say, how do we do this? The abstract. You'll see an abstract. It's usually made by the author, but unfortunately can really reflect bias, may be misleading, might not explain the study methods, and is usually not a good gauge of a study's validity. Because remember, what is the salesperson trying to get you to do? Read their article and make that a basis for practice. So the abstract is just what it is. But don't make decisions based just on an abstract. You might be going in the wrong direction. What do we look for in the introduction to anything that deals with EMS literature? Any kind of scientific literature? What's the problem? Because there's a litmus test that scientists have to pass, whether it's the professor of chemistry or whether it's you doing research. And that is the two big questions of so what and who cares? And the introduction is supposed to answer that or help you stay that. Find that out, excuse me. Why are we doing this? So I can get my grant funded? I hope not. Gives us some background information. What have we always wanted to know but have not found out yet? And what is the history behind what we're studying? And it's very brief. If you don't know where you've come from, it's hard to figure out where you're going. How did we get ourselves here? And that's usually in an introduction. Most of these papers include some type of literature review. And basically that's saying, what have others found so far? It lets readers know we're not suffering from some mental anguish going through all this. There are other people who are looking for these things. And it lets us know what has been recently found. Somebody handed me an article. They said, can we teach people how to read EMS literature? This is a good article. And it had to do with ACLS. I said, when was this from? And they said, oh, 2004. That's not recency. That's ancient. It doesn't mean everything they did was wrong. But we need to figure out before we research anything and try to make conclusions, what do we know so far? Methods. Probably the most important part of the study. Now, let's be honest. For those of you who are doing this, picking up the research, looking at it, what do you go to first? The answer. Is it telling me what I want to hear? Most researchers, most physicians who do research will tell you the first thing they turn to is the methods. How was this collected? Did we control for our biases? And everybody has them. Lots of times, we don't even know it. It's just what we're used to. Is this just another paper that somebody was looking for an answer, came up with an answer, then decided to research, how do I get my data to do this, to look at this? Who are our participants? We don't really judge anymore in EMS professionals having to do with a paycheck. But there are differences in the variables for volunteers and career, depending on what you're researching. Who did we get to participate? If we asked people to do something new, did we measure the results from the hands of who's doing it? Or did we give it to one group and think, well, it will automatically be okay in the field, or for another group? And that was a lot of our previous adoptive methods. Well, it worked in the hospital. It worked in the ICU, worked in the ER. But you can't conclude that it'll be good in the field when you weren't in the field and you didn't use people who deliver service in the field. And that's why knowing the methods of this, and what makes research challenging. And I will tell you, when you participate in a research study, no matter how small, that will give you the most headaches, because you have to be meticulous, or else it will compromise everything that you're trying to do with that. The method section, it tells you a lot, and frankly, it can tell you whether it's even worth your time. There's a few things we need to know. Is what we're looking at quantitative or qualitative? or mixed method. Quantitative is the one with the big numbers and the statistics, where qualitative is more of getting into the weeds of things. We don't always have enough data to give you a statistical report on things, but we have to start somewhere. And sometimes that's just interviews and answers people give, and calculating how many times does the paramedic, when we talk about CISD type of things, how many times do the EMTs or firefighters use the word injure myself or suicide? Well, we start getting this information by doing qualitative types of research, intense interviewing. And it might not produce the statistics yet, but it's going to get us started and say, we really need to look at this. Now you might say, how do we judge whether a methods section of a paper that we read is good enough? One of the things I like to do and recommend, whether it's my doctoral students at Capella or my NFA executive fire officer students, is look at the methods. Could you take the methods and repeat them in your jurisdiction, in your department, at your station, without having to do a whole lot? That's a well-written methods section. Yes, it's neat to know statistics. From a management perspective, for our executive fire officers, I don't teach formulas. I don't care if you know how to calculate chi-square. I do care if you know what it means. And I do care if you can apply your knowledge, look at data and say, yes, this is what we need, or no, something's not right about this. I may need somebody who is more attuned, who's maybe even smarter, but I know this well enough to say something's wrong. And did the researcher even admit that there were some flaw in their methods? Were any problems encountered? Sometimes we would like to do things in one way, but we can't. Sometimes it's method, or sometimes it's what we're trying to do. Sometimes it's ethics. We are not yet able to design a study that protects everybody. And that includes you. And we have to be able to figure that out. So that's the methods section. And I didn't want to get much further into it because later, if people have more questions and want a little bit more, I can help you. And not have the people who are not ready for this yet to have to sit through it. What do our results section do for us? Well, it re-emphasizes what's the description of the study. If we're studying groups, were they different or were they similar? Were there any confounding variables? What do I mean by that? Did something introduce itself that we weren't ready for? For example, if we looked at certain treatment mechanisms, but we didn't look at the difference between EMTs and paramedics, or EMT intermediates and EMTs, our results might be skewed. Maybe this intervention was good in one hand, but for one group, but maybe not for the other. And the results tell you, what did we find? Did we answer our research questions or our hypothesis, which we formed early? And we can talk about it some other time. Did we find it? Did we find nothing? Did we find that we can't give you an answer? There's just not enough data. Another important thing is the discussion section of any type of research. And that compares the researcher's results to their literature review. The literature review cited 5 studies that answered some of our questions. What if your study came out with a different answer? Did your findings agree or disagree? Or challenge everything we thought we knew about this? And it is important that we're able to do this, and not 15 and 20 years later, where we've committed. This is the only time in scientific research where the author can interpret the results and give their interpretation. That's where they do it. Before then, it's just the process. And what did we find? Did you confirm or refute what you thought you were going to find? What is most common in many of these things is, did you find results that provoke more questions? Or did you just find nothing? And you have to go back to the drawing board. Or maybe you don't. Maybe there's nothing to find. And you know what? We can fool a lot of people. We can be dishonest. But you really can't fool yourself. This is your profession at whatever level you are. Now, you say, well, what do we have to study here? Don't we have the answers to everything? Gee, back in 1899, the federal director of permits and copyright said, we can close my office. There's nothing left to invent anymore. How wrong was that? One of the things I've wanted to look at are the terms ALS and BLS may be antiquated. Some things, they're not basic, but they're essential. And so do we need to look further and find what is essential life support? And then what's the rest? How about the proper technology? How much is too much? There are ambulances available now with CT scans. Isn't that great? But does that system get enough patients each year that will do that, that will benefit from it? What about pharmacology and procedures? Would anything that we do today meet FDA approval just like a drug has to? Think about that. Yeah. How about backboards? Not
Well-
only with backboards did we do things that weren't necessary. Did we hurt people?
Yes.
Measured out IO2 levels when we put straps across their chest. And then we said, but wait a minute, what about the management part of this? What's the difference between bringing a patient to the ED sitting up versus lying down? There's a big difference. How about these new and out of control diseases? Now I'll do a little soapbox here. I got to look from the outside in to things like COVID-19 and COVID injections. Now, I love public health people. They do a great job in what they do. But they tend to be 9 to 5. That's what they tend to do. They're good at it. But a disease popped up that was 24 hours, was not only public health, but public safety. So I, like most of you, got into one of these lines for however long it was to get my COVID-19 shot. But I thought about this for a while. And I said, that's great, we vaccinated people. But was it and were it the people who needed the vaccine the most? Were the people who we really needed to get treatment to? What if we took 50 COVID vaccines, a computer tablet for writing, and gave that to station captains and said, go find 50 people who are our biggest risks and make sure they get this shot. The ones who aren't going to come stand in line. And my hypothesis is, I would like to do this, is to say, I will bet you our company officers, regardless of what their medical training is, I'll bet you they can find the people in their community and go right to them and make sure the most vulnerable people are actually treated. And we'll talk about how that's happening a little bit, just a few minutes. How about EMS systems? How many people? We talked about that. How many paramedics? What about EMS medical direction? What are the guidelines for a system that needs a full-time medical director? What are the real qualifications? You know what the qualifications were when myself, and I know without seeing the pictures, some of you came in, a doctor who would sign the paper. What about other physicians, nurses, PAs, other providers? No, why are we short on people? Because we're going to take these people and they're going to start at day one of training. Why? We can't afford to do that anymore. EMS quality management. How right is right? Are we doing what we need to do? There are quality management measures that we can do in EMS. If you want to learn about it, it's a free 6-day course at the National Fire Academy on EMS quality management. Dispatch. Often forgotten, but I believe is one of the most critical aspects of what we do, of our system. And it's the old story of the chief who didn't like his or her response times So the suggestion was, let's build more stations. Let's throw more equipment out there. Let's put more people out there. Only a year afterwards to find out that there's been no change because the deficit was in our dispatching the call. And the data is there to show that. We just often don't look at it. And we need to start, or we're going to keep repeating the same mistakes. And we really have this big fascination with time. What does it really mean? And can you interpret it? If you're an EMS manager, I hope you can. And we have to start teaching our people that early on. When I ask people, have you evaluated your EMS response times? And they often say to me, well, yeah, Harold, we did. And we know about our average response time to this, this, and this. And it's like, what does average tell us? Nothing, really. It means 50% of the calls are above the mean and 50% are below. Now, chief officers, volunteer chiefs, you think that's going to convince your board of directors or your county council to approve something that costs money? What if your job or position are on the line? Average? On average, every human being has one testicle and one ovary. I know you're looking at me funny, but what I'm telling you is the truth. On average, what does it mean? That's why NFPA 1710 talks about 90th percentiles, just as your medical directors will say, I want to know what happens most of the time, not just the mean. Unanswered questions. How about EMS education? We got a lot of unanswered questions. Competencies versus hours. You require 48 hours, and this one requires 16 hours. But are we demonstrating competency? And if EMS medical directors have to decide, are we going to put RSI or medication-assisted intubation in the field? Do you think they care about hours, or have we demonstrated competencies? The National Registry recently eliminated and is eliminating the practical for paramedic. And people say, why? Because they figured out we now require EMS education facilities to be certified, if you will, or recognized, have medical direction. Isn't that taught best there? Look at other medical professions. Yes, even some physicians. I'm a board certified healthcare administrator. We used to have a practical exam. That was eliminated because I had to prove that I went through education and training that was credentialed. And we're starting to see that if we want to be considered a profession, there needs to be a national certification. Licensing is a state level thing. Privileges or credentialing is a jurisdictional level thing. Your managers and your EMS medical director. So why do we need to have all different kind of tests? None that we've demonstrated actually prove anything. Maybe it's the type of test, but these are unanswered questions that you are going to be the people to come up with. So what's our practitioner's role here in EMS? What do you have to do with it? Isn't that for the doctors? No. This involves every provider, regardless of licensing level. You are the critical factor in data collection. It wasn't like it used to be. We filled out dots and people yelled at us. But we never did anything with it. There's a ton of information. And not only are we ready to think about what we do, but research helps everybody else. What are we doing across the nation, across the world? But you have to collect the data. You can use data. You have an idea to research something, bring it to your EMS officers. Involve the county's EMS staff and the EMS medical director, even for local simple studies. First, we want to know, are people doing it? Secondly, is it being ethically accomplished? Third, is help available? Is help available? You don't have to go it alone. And yes, you can start. You don't have to be going for your Ph.D. You can. Simple things. How often do EMS providers take vital signs? You know, we don't know the answer to that. We don't know the answer. Something that simple. Because we need you involved. You need to maximize the use of your data tools, using it properly and asking the right questions. What's your role? Get involved. You can't do it without me. And get other people involved, other medical providers. A lot of times they may have the things that you need. And you know what? You may have the things they need. Don't be ashamed to ask for and accept help. And you know what? Sometimes you find it. Sometimes it's even money that you might find. You never knew was there until you got involved in research. And I'm probably talking for too long, so I'm going to just do a couple more things. First of all, what are the dangers of leadership and research? Don't expect to be famous. Don't expect to be loved. Don't even be expected to be believed, at least right away. Be ready to not like what you find, but understand you must find this. You will be the shot messenger for a while. But you may be the first to know something that others are not ready to understand. And that's what our profession needs. Our own science to do this. Hey, you're already doing this. Is diltiazem safe and effective in the pre-hospital environment? You see all these names here. They're Maryland people. They're Maryland physicians. Who collected their data? You did. And it was your data that showed, usually, in most cases, there is improvement. And in uncommon times, there can be side effects, but we've been able to manage that. Just 20 years ago, 30 years ago, what did you do for atrial fibrillation with rapid ventricular response? Well, we got them to the hospital. We'll give them medicine there. But we're finding out that maybe more damage is being done the longer that they're in this rhythm. And you've been doing this for years. I just opened one of my things I published in 1990. You all collected the data for me. Thank you. We came out with some good stuff. We knew that we came out with that we've been safely using Valium. Now there's better things, but at the time, we were able to use the sedatives, and paramedics, CRTs, were doing it correctly because they only gave enough to stop the seizure. They were watching. And nobody ever measured that. We did 30 years ago. So this is nothing new. It's just become more out there, more popular, and we're getting more people involved. Overdose treatments. Yeah, anybody can give Narcan, almost any direction. God, I think if you rub the stuff on, it eventually will work, but that's not all this is about. What about afterwards? What about getting people started on the medications similar to methadone, but better, that will help them start to recover from their addictions? Or at least get them, if they don't want to go to a hospital, to a place where people can help them. And what the preliminary evidence is showing us is that you can do that when we do that. Now, we got to be careful. We're starting to consider upper or lower extremity for intravenous access. Nice study. I'd like to know that. Is the arm as good as the leg? And the answer is, we're not sure. We took all that data that you and your fellow EMS professionals collected. Now, the upper extremity was associated with greater return of spontaneous circulation. But if you look at the numbers here and you understand what you're looking at, odds ratios and things, not by a whole lot. It was constant against multiple patient subgroups. We also found in this study that it increased survival to discharge and survival to home. But don't take this as gospel. We're talking, you're not at 1.5, or some even say 2 with your odds ratio, you can't make an assessment. What this did, however, is confirmed what we've known for years, that technically, anytime you're going to resuscitate somebody, it's better to gain access above the solar plexus versus below. And now that I said that, that's being challenged, because now we're even looking at moving that leg sight from below the knee to just above the knee. Stay tuned. You're going to hear stuff about that. How about community risk reduction? How many of you all like going to those nursing homes and picking people up who have fallen, and for them to say, we're not a lift facility? I know sometimes you want to say, neither am I. But an EMS system in North Carolina actually did something about it. And they sent people to these lift assists, but they also contacted the primary care provider. And almost 63% of the time, they didn't need to transport this person. And there was a very low error rate. This is what research did. It allowed people to do something about it. Not just say there's nothing we can do. And please don't forget our dispatchers. Can we shuffle calls off to other agencies or to telemedicine, etc.? Can dispatchers do that? The beginning data says yes. And that can mean a whole lot. So let's end this and say, what do we need to do? Why is this so important? Why do we need to be passionate? Because it's what's going to pave the way to our future. It may keep us from making some missteps. And I already see people publishing, well, will EMS exist? Yes, it will, if we do what we're supposed to do, if we act like medical professionals. And it starts with you all to do that. It's nice to know that what we're doing makes a difference and that we can make decisions about what doesn't need to be done anymore based on evidence. Well, I'm going to stop. But somebody's monitoring the chat. And look, any of you who want to talk about this further, give me a call, send me an email. I'll be happy to. Even if you think you don't want it in front of everybody, I'll do whatever we need to. Okay.
First question. Do you know about NEMSIS, a National EMS Database Warehouse that you can request targeted data sets from? For example, all females over 50 who had a stroke alert called of an SDP over 200 that were actually CDA. I heard about this through Pennsylvania EMS conference, ConEd. EMS is the only healthcare sector that has something like this.
Yes, the answer is absolutely. And we're getting better. More and more states are adopting it. Simply, I know it sounds simple, states are sending this national database all of their run data, and they're able to share it with you. It's kind of like what NIFRS is for fire, and NIFRS is changing. It's becoming NEMSIS, not NEMSIS, it's becoming NERES, and part of that data management program will have something to do with how do we manage fire and EMS data and things like that. Absolutely. NEMSIS.org, and they are congressionally mandated to help you. If you call them and say, I need your help in this, they're supposed to do that because they have to report to Congress every year to get their funding. So that is one of the national EMS databases. We didn't get into that this time. Also, there are other databases. Where are your knife and gun clubs? CDC, Whiskers, WISQUARS. You can look those up. What are the top 5 or 10 causes of death for certain ages? Just go right on the website through CDC. Yes, trauma databases. The trauma junkies who, hey, we like collecting trauma data. It's there. You may have to do some work. You may have to get your medical director to help you or someone else. But most of the time you can access these things. Excellent question. And again, time was running out, but if you attend the NFA's EMS quality management, we do quite a bit with this. Anything else I can answer?
Do you have any recommendations about funding for research?
Yes. Find somebody rich and do exactly what they do. Other than that, apply. Apply for things. If you're doing community risk reduction projects, if you want to do a drowning prevention program, fire prevention, who's doing more risk reduction. Sometimes the words fire prevention are misnomers because some of these grants are looking for are wide bases. Number of websites that you can do that. Project 2020, which talks about risk reduction. Go to that website, you'll see a lot of EMS. And regardless of what we want to think, the fire that never happens, the MI that never happens, the multi-system trauma that never happens is the best way to go. Remember, once we have to start treating people, those are our failures. The system failed somewhere down the road, or I don't want to use fail as a pejorative. I want that to be, we didn't do as well as we could because it happened. Why did kids that fell off of this jungle gym from this playground have bad head injuries? Well, we noticed that they're all using concrete for their grounds instead of a softer agent. Here again, what we do for the head injury, that's great. Preventing it is the best thing. I don't see everybody, so I can't tell if you're giving me the finger, making fun of me. Everything. It's okay. I'm used to it. Anybody else have anything? Somebody talked here about the military. And military medicine is not civilian medicine. So you can't automatically do something. But you know what? The military branches now are putting their medics through National Registry, EMT and Paramedic. So they're coming out more prepared. So the days of, we got to start you at day one, hopefully can come to an end. And some of these military medics, independent duty corpsmen, they can do a whole lot. So they do have to get acclimated to civilian EMS, but they've got a lot to offer and can sometimes fill the gap and can start filling the gap. So I saw that question. Here's one. Good question. Department can. You did? Oh,
Yeah.
good. And there was, you know, there's just a decision that came out today in New York. Somebody tried to sue because they, FDNY sent a BLS unit. And it was really an ALS call. And the EMTs got there, and instead of packing the patient up and just going to the hospital, they called for an ALS unit. And the family felt that that was wrong. The New York court said, no, as long as people are operating under the way they're supposed to operate, under their protocols, under medical direction, that's not recoverable. Now, it doesn't mean we're never going to get sued, but I thought that was an interesting thing I saw today that just came out.
I would like everyone to check the chat and look for the link for continuing education. Hit the link, fill it out complete and accurate so you can get your continuing education credit. This was, I will point out though, for the state of Maryland at this time. And this is all done through MIMS. I want to thank Dr. Cohen for coming here. We had a lovely chat just before because we go way back. Lots of good memories. And his email address and his website are on there. I can assure you Harold is quite approachable and he loves to talk about all of this stuff. And he's pretty knowledgeable. I actually used him many years ago to help me study for my anesthesia boards down at headquarters from many occasions. And
I'd like to thank Dr. Sagal for having me. And we can kid about this, but I had good EMS medical directors when I was in charge of EMS, but nobody as involved as your EMS medical directors today, like the late Dr. Barinholtz was, and Dr. Sagal, and some of the others I haven't met, and some from other specialties who might not be able to come in the field, but can offer you things within their specialty. So thank you, Doctor.
Thank everyone for attending. Again, we will post the next lecture in another week. We are scheduled basically through till next summer. I look forward to these educations. I was always told a long time ago, one of the goals of the instructor is to be 1 week smarter than the students, and then you'll be successful. So that's I think we should achieve that. When it comes to research, I can tell you the state of Maryland is involved heavily in eMeds, and they collect their data. So accurate reports help.
Yes.
Information is gold. And the Baltimore County mines information every week on its calls to see what we're doing, what we can improve, or what's going on. We've, in the last year in Baltimore County, instituted a much needed quality assurance program, and it's been getting more vigorous. And its purpose is to learn and educate. What can we do better? It's not done to punish. It's quite the opposite. It's what can we do to improve? And
quality management is not a verb.
No, it's not, and it's important. But it's like when they tell you this is the way we do it because that's why we've always done it. But you have to ask, is that right? Or and have quoted a couple of famous examples with like mass trousers. I remember when they first came out, and then you kind of wonder at the end, how did this happen? And then they're looking at backboards. Backboards, it's a double-edged sword. When does it become more of a problem than the thing? And this is all currently being researched, and we need the data.
And we need people to take this over. And I forgot to mention, this week we lost probably, arguably, one of the most famous EMS researchers and medical directors, Dr. Ron Stewart. And I just saw that last night, and he was, even though he was an anesthesiologist, and he was one of the original medical directors in LA, and then came over to Pittsburgh, that has an emergency medicine residency that concentrates a lot on EMS. He always talked to everybody. He tried to get everybody involved. So, you know, some of you who've been around for a while may have heard of him, and we lost him this week. So who's going to take his place?
I can tell you in research in airway management, video laryngoscopes are going to replace a tool that's been used for the last 50 years. However, what they can do and what they're accomplishing, it's just amazing. And the success rate's so much better. That all starts with basic research, and someone gets an idea and then wonders if it works, and then they do a study on it, and then it spreads. But it all starts with you and identifying a need.
Rotating tourniquets. I haven't seen anything on that recently.
I haven't even seen them in use anywhere. That was for a heart failure
Yeah.
originally in the field. Now we diuresis. It's
Interesting question.
I can't even remember the last time I've seen one used. It's been over 20 years.
It's been a long time.
But it's this is the coolest job in the world. At least that's what I think. Does anybody have any questions where they can send it in the chat on CEUs? You can text me right now, and I've been taking information from people. And other than that, thank you for being here. We can only do continuing to add rooms right now from today as a lecture. If you want to watch the video, you know, obviously certainly you can. It'll be put out on the website for anyone to review at a future point. But we don't have a mechanism for continuing ed after tonight. A work in progress for the future, just not quite there yet. We have to go through the FRA.
Thank you.
Thank you for
Good
being
luck to
here.
everybody.
This was a very nice conversation tonight.
Thank you very much. Great class, Doc.
Thank you, everybody.
Thanks so much. Have a good night.